Hi, my name is Eva, and I'm going to be talking today about sexual sadism disorder. So sexual sadism disorder is a paraphilic disorder. A paraphilia is an intense and persistent sexual interest in something other than a typical sexual behavior. So as defined by the DSM-5, typical sexual behavior refers to either preparation for or consummation of sexual activity with a phenotypically normal, physically mature, consenting human partner. So non-typical sexual interest or behaviors would be anything that is not related to that kind of phenotypically normal, consenting human partner. And this may sometimes be described as a preferential sexual interest rather than an intense sexual interest, because intensity is not equally meaningful across all populations. Paraphilias have two different categories, or paraphilic disorders have two different categories. One type is an anomalous activity preference, which refers to kind of a focus on non-typical sexual behavior, which can further be broken down into courtship disorders, focusing on distorted courtship behaviors, or algolognic disorders, which focus on the infliction of pain or the experience of pain as a sexual outlet. The other category of paraphilic disorder is an anomalous target preference, which refers to a focus on a non-typical sexual partner or object. Sexual sadism disorder is, as I said, a paraphilic disorder. Specifically, it is an anomalous activity preference, and more specifically, it's an algolognic disorder. So it is something where an individual derives pain or derives sexual pleasure from the pain, suffering, or humiliation of others. So the criteria for this disorder under criteria A are that an individual must experience sexual arousal from the suffering of others. This arousal can be from the either physical suffering or psychological suffering of others, and it can manifest in terms of fantasies, sexual urges, or behaviors. Typically, clinicians look for around a 6-month duration at least, just to make sure that this interest in pain in conjunction with sexual arousal is not a transient condition. However, diagnosis may be made after a shorter period of time if the interest in pain in conjunction with sexual arousal is clearly sustained. Criterion B for this disorder is that an individual has either acted on these urges or has impairment or distress in social, occupational, or other forms of functioning due to this interest in this sexual arousal in the pain and suffering of others. Both criteria must be met in order for a sexual sadism disorder to occur. The mean onset for sexual sadism disorder is during young adulthood, so about 19.4 years of age in young men, and again during young adulthood in women. In terms of prevalence and representation, this disorder has been found to differ based on sample. One Australian study kind of trying to look at sexual sadism disorder outside of a forensic population sent out surveys asking about sadistic sexual behaviors over the past year, and found that among their sample about 2.2% of men and 1.3% of women had engaged in sexual sadistic behaviors in the past year. However, that's not necessarily indicative that that entire sample has sexual sadism disorder. The behaviors asked about by this study included bondage and discipline and sadomasochistic behaviors, which may have been consensual in nature and thus exemplified sadistic sexual interest, not sexual sadism disorder. In terms of the disorder itself, much of our knowledge comes from forensic populations. We know that the forensic samples that we have been able to identify are almost entirely male. Among sex offenders in the U.S., less than 10% have sexual sadism. However, if you look at offenders who have committed a sexual homicide, rates of sadism, sexual sadism disorder range from between 37 to 75% of the population based on the criteria used to define the disorder. In terms of prognosis and cultural considerations, sexual sadism is, as a trait, most likely a lifelong characteristic, but sexual sadism disorder itself may change in intensity over the course of one's life. So it may, an individual may experience different levels of distress at different times in their life. They may experience different propensity to harm others. And typically we do see that sexual urges decrease with age. So as somebody kind of becomes older and has a natural decrease in sexual drive, they may experience less interest in this kind of sexually sadistic behavior. Cultural considerations are just once again the fact that we've studied this disorder largely in either clinical or in forensic populations specifically, and we have not really been able to identify much about this disorder in kind of outpatient samples. Previous literature regarding this disorder involves something called the Psychopathia Sexualis, which was written by Richard Kraft Ebing in 1886. This was the first published work to coin the term sadism, which was referred to as the experience of sexual pleasurable sensations produced by acts of cruelty or bodily punishment inflicted on one's own person or when inflicted on others. This definition has since been refined to the experience of sexual arousal from pain being inflicted on others. We do not include pain being inflicted on oneself under sexual sadism disorder anymore. That is typically something that is connected with sexual masochism disorder. There was also a personality disorder in the DSM-3 revised version, referred to as sadistic personality disorder. This was a non-sexual form of sadism, which focused primarily on sadism associated with dominance-associated personality traits. This disorder was eliminated from subsequent versions of the DSM because of a lack of empirical evidence to support it as a distinct disorder. John Money in 1990 did propose 5 distinct etiological pathways for sadism, including hereditary disposition, hormonal functioning, pathological relationships, sexual abuse syndrome, or symptom overlap pathways. There's more information about these in the handout that I will provide, but essentially these refer to either neurobiological or social factors that he felt could influence sadism. There have been further neurobiological explanations proposed with, again, John Money, proposing that sexual sadism may be connected to malfunctioning of the limbic system, causing the brain to send signals related to sex in conjunction with signals related to violence, and several other researchers finding that sexual sadism disorder is connected with malfunctioning of the right temporal horn. And those systems are kind of outlined in the pictures on this slide. Differential diagnosis typically includes the idea of sexual masochism disorder. Both of these disorders share kind of a focus on pain as kind of a sexual stimulant. However, in sexual masochism disorder, individuals are aroused by the act of being harmed or humiliated, whereas in sexual sadism disorder, individuals are aroused by harming or humiliating others. Another differential diagnosis that you might want to consider is antisocial behavior. We typically see this because these disorders are fairly comorbid, at least in forensic samples, and they do share some kind of the infliction of pain on others is present in both disorders. However, in antisocial behavior, or antisocial personality disorder more specifically, there's not the sexual component connected to the infliction of pain on others. Sadistic sexual interest without sexual sadism disorder is also a possibility. And this kind of refers to the idea that sadism might not result in distress or impairment to an individual, particularly if they only practice these behaviors with a consenting adult partner, in which case there's not the criterion are not met for a diagnosis. So we would refer to this as sadistic sexual interest without sexual sadism disorder. There are also some other disorders which may be comorbid with sexual sadism disorder, including antisocial personality disorder, sexual masochism disorder, substance abuse disorders, or hypersexuality. In terms of assessment and treatment, we typically rely on self-report or legal data to assess sexual sadism disorder, and that can be assessed through the sexual sadism scale, the severe sexual sadism scale, or the short sadistic impulse scale. Those are all psychometrically valid assessment forms that have been created for this disorder. In terms of treatment, we typically look at things like psychotherapy, including cognitive behavioral therapy to help identify underlying causes of the deviant sexual behaviors and to kind of manage sexual urges in a more acceptable manner. These may include aversion therapy or imagery and desensitization, which aim to reduce future interest in sexually sadistic activities by associating them with unpleasant outcomes, and cognitive restructuring, which works to identify and change the thoughts that shape inappropriate sexual urges. This may also include empathy training. In terms of medication, people with sexual sadism disorder may be prescribed medications to reduce circulating testosterone, which reduces sexual fantasies and the ability to maintain an erection. And they may also be prescribed like antidepressants or other medications which will reduce sexual desire. Case presentation. I'm going to let you guys read this vignette on your own, but essentially a 32-year-old male is brought in to see you after raping a woman in a nearby park. During your initial interview, he reports that he began viewing pornography in his late teens and was most aroused by material showing people being humiliated or harmed. He admits that in the past he enjoyed sex most when using demeaning or derogatory terms towards his partners, and that several past relationships have ended because his partners felt his behavior was becoming too intense or because they were disturbed by him expressing a desire to hold a knife to their throats during sex. Aaron claims that his sexual urges recently became too strong to resist, leading to the rape for which he was brought in. When questioned about the rape, he confirms that seeing the woman's fear was just as good as the sex, and admits to inflicting unnecessary cuts on the victim during the assault. In terms of differential diagnosis and symptoms here, we see that his behavior has been going on for at least 6 months. He experiences recurrent sexual arousal from the humiliation and suffering of others, the urge to cause pain or humiliation in others, and he acts on the urges with a non-consenting person, with the sexual assault of this stranger. In terms of a differential diagnosis, Aaron derives sexual pleasure from inflicting pain on others, but not from having it inflicted on him, which rules out sexual masochism disorder. The non-consensual nature of the attack rules out sadistic sexual interest, and there are no signs of other sexual disorders, including transvestic fetishism, hypersexuality, and no signs of any kind of substance abuse disorder, which, as I've said earlier, may also be comorbid with sexual sadism disorder. And this is the citations page.